This recording is the second part in talking about sensory pathways, or specifically somatic sensory pathways. This recording is going to just do a brief overview of the pathways, but then specifically addressed the pathway involved in transmission of pain impulses. Now, what you see here is a section of the spinal cord, and the colored areas represent different tracts that are going to be involved in transmission of somatic sensory information. We will look at the lateral spinal thalamic tract, which you see in the lateral white column on either side. We'll be talking about that because we're going to be talking about pain. But we also have in those lateral white columns these spinal cerebellar tracts. So you have posterior and you have anterior spinal cerebellar tracts. Those are both found in the lateral white column. We'll be looking at those. They'll be involved in transmission of proprioceptive information. We'll also be looking at later time is this part of the posterior column pathway. You have the fasciculus cuneatus tract, which you see over here, both sides, and the fasciculus gracilis tract right here. They'll be carrying information in regards to discriminative touch, vibrations, pressure, that type of information. Now, the anterior spinal thalamic tract, which you find in the anterior white column here on either side, that's going to be carrying information in regards to crude touch and just kind of non-discriminative touch. So we'll be looking at that at a later recording. But it's important to make a mental note of the location of various tracts that are part of certain pathways. So collectively, you see the fasciculus cuneatus and fasciculus gracilis tract are part of the posterior column pathway. The anterior and posterior spinal cerebellar tracts are part of the spinal cerebellar pathway, and the last two are part of the spinal thalamic pathway. It is important to know the location of these tracts, because if we damage a specific area of the spinal cord, you can determine what type of sensory information would be lacking in that particular patient. And it's also important when we go through the pathways is following the direction of that pathway, where it decussates, because if you know where it crosses over, you can determine where we're going to lose sensations below that level of the damage. Will it be on the same side as the damage or on the opposite side? So you kind of need to know where the crossing over takes place. So we're going to be going through the pathways mainly by the classification of receptors, which are classified by nature of stimulus. So we're going to start with the nociceptors. So the nociceptors, you can spell it this way, or nocioceptor. The nociceptors are going to be sensitive to painful stimuli. They have free nerve endings, and they do not adapt. So they are tonic receptors. So they are not phasic receptors. They do not adapt at all. They're always on. This is important because you need to be aware if something's painful, because it could potentially lead to your death or injury. So we want to make sure these are always on. But we will mention later that we can modulate the pain where it's not going to be as bad. Once we know that it's painful, say, yeah, we know it's painful. Can you dampen it a little bit? Because I don't want to deal with this pain. So we'll talk about that later. Now, the nociceptors, or nociception, is the only visceral sensation that that can be perceived. So remember, sensations are different than perceptions. You're going to have a sensation without a perception. So ones that we're actually aware of is, in regards to visceral sensory receptors, is actually the pain receptors. Now, what type of things trigger pain? Well, you see a whole bunch of stuff. Don't try to write everything down, but mechanical damage, chemical changes, insufficient blood flow, ischemia can do it. A number of different things can trigger pain. Now, when we talk about the pain pathways, we're going to be talking, and actually all these sensory pathways, we're going to be talking about first, second, and perhaps third order neurons. Now this picture does depict first and second order neurons, and these are specifically afferent neurons because they're carrying sensory information. The sensory neuron, which you've learned about previously, is actually the first order neuron. That's carrying that information from the periphery to the central nervous system. In the spinal cord, which you see here, you see this right here is our second order neuron. Now, the cell bodies of those second order afferent neurons are located in the dorsal gray horns, which you have previously learned is that's the location of somatic as well as visceral sensory nuclei. So those nuclei is that group of cell bodies, and it's of these neurons. Those second order neurons are going to be carrying that information up towards the brain, and specifically in the painful pathway, we will have a third order neuron, but not every sensory pathways involve third order neurons. But third order neurons will be involved, and we're going to look at that in a moment. So we're going to apply a scenario, and we're going to draw, and I recommend using different colors, and you're going to have to add stuff to these pictures. And so we know what we need to add is on either side of the spinal cord, you're going to need to add the rami. And so you have the ventral ramus and you have the dorsal ramus. So here's the dorsal, here's the ventral. So those are the branches of the spinal nerve. So you do have to add that in. So you have a section of the spinal cord. This picture here is a section of the medulla oblongata. This one is the midbrain, so we're going up through the brainstem. This here is the top is a coronal section of the brain. The reason why I have a coronal section because I want you to see the thalamus, and these are the two thalamic bodies that you see right here. Okay, so here's the scenario. You stepped on something that was very painful in your left foot. We need the information to get up to the brain so we know, oh, something's painful in my left foot. Well, if it's coming from your left foot, it's going to be traveling up that left foot through the nerve that's going up through your leg, into your thigh, and eventually to the spinal cord, and it's coming in on the left side. So that information is going to be traveling on this side here, and it's going to go to the spinal cord. So let's look what happens. Now, on this picture, I don't have my ventral ramus and my dorsal ramus labeled, but you will have had this here. This is going to be traveling along the ventral ramus. So it goes to the ventral ramus because the ventral ramus carries information to and from your limbs as well as your anterior lateral body wall. The dorsal ramus comes from your back. So the red represents your first order neuron. So that first order neuron will then synapse on the second order neuron within this region right here, which is your dorsal gray horns. But I want to label some stuff so we kind of remember some of the stuff that we've learned previously. So you see that axons traveling along the ventral ramus. Here's the cell body of that first order neuron. That's in the dorsal root ganglion. Here is the axon of it, and that's traveling along the dorsal root. And then we come here to the dorsal gray horn. So just remember, if I damage a dorsal root or a dorsal root ganglion, I would have problems with feeling things because it only carries afferent fibers. Now, once we get to that dorsal gray horn, you see the blue. So the blue is going to represent our second order neuron. So the cell body of the second order neuron is located in the dorsal gray horn, and you see it's going to cross over or decussate to the opposite side of the spinal cord. And in the gray represents the lateral spinal thalamic tract. So the lateral spinal thalamic tract has myelinated axons carrying information in regards to pain up the spinal cord. It is an ascending tract. So you see the axon of that second order neuron is traveling up via the lateral spinal thalamic tract, which is located in your lateral white column. So it goes all the way up, goes through the brainstem, comes up. Eventually, it's going to hit the thalamus. So the second order neurons will synapse with the third order neuron in the thalamus for initial processing. So on this picture, the orange represents your third order neuron. The cell bodies are located in the thalamus. And remember, the thalamus is a central relay station for various sensations, except for smell and subconscious proprioceptive information. So this information came from your skin. And so here it's like, okay, it came from the skin, it came from that left foot. So what we need to do is I need to take it to, ultimately, to that primary somatosensory cortex, which is in that parietal lobe. And remember, that's located in the post-central gyrus of that parietal lobe. And you notice it went here. It didn't go over here, it went here. Well, because it knew it came from the foot, it knew it had to go to a specific region of that primary somatosensory cortex for that final processing. So if you look on this picture, over here on the right is representing your sensory homunculus. So this is your mapping up there in that post-central gyrus. And you'll notice that if the information came from the genitals, you see it's right here, low down on that longitudinal fissure. The feet, that's where you saw where I had that information went with that scenario. And as then we move up, as the information's coming up from further up on your body, that's going to be processed more laterally along that primary somatosensory cortex. So by the time you get here closer to the lateral sulcus, you're down in the tongue in the pharynx region. So, just give you an example that if a neurosurgeon was to stimulate a particular area in that primary somatosensory cortex on a conscious patient, they're going to feel something coming from a specific region of the body. And also is, to remind you, is that where you see like kind of exaggerated dimensions, exaggerated sizes of body parts, the reason why you see things like the hands are exaggerated and you see teeth here and lips, you don't see teeth or lips over, or you have lips but not much, is over on the motor homunculus, is areas of the body that are more sensitive, that we're going to have certain more areas within that cerebral cortex that's set aside for interpreting information from that body, from those body parts. For areas that have a lot of discriminative touch specifically, you see that a lot of that. So you notice there's not, the trunk is not that big, the feet and the legs are not that huge, but you see the hands are pretty large, and you got the large lips, you see the teeth. So that is more involved in sensory type of information. Now, that pain can be described more than one way. We can have what we call acute pain or chronic pain. And if you look really carefully, you see C fibers and you see A fibers because they carry different types of pain. So I wanted to compare acute pain versus chronic pain. So let's go through acute pain, then we'll fill in chronic pain. So acute pain, like I stepped on something that cut my foot. I'm well aware of the fact that my foot got cut very quickly as long as all my nerves are good. So if I had, say, damage to my sciatic nerve, I might not feel that painful stimuli in my foot, but we're assuming everything's normal. With acute pain, you're aware of it very quickly. Now, the reason why you're aware of it really quickly is because the information is carried along fast fibers, and those fast fibers are type A. Now, type A fibers are large in diameter, and they're heavily myelinated. So we're going to get that information up to the brain really quickly. Why is it so important to know? Well, it protects against further damage. You need to be aware of it very quickly so you can protect against death or further damage. Now they describe, it's hard to write very neatly with fat styluses. Now, the pain is actually described as sharp or pricking. Now where it's felt, it's going to be very well localized. You can localize acute pain. It's usually associated with the skin. But when does that pain resolve? Well, you can have pain without injury though. And so if you remove the stimulus, or if you do injure yourself, if it's healed. So after healing. Well, what about chronic pain? Well, chronic pain, purpose, I'm going to say big question mark, because why do we have chronic pain? Why do people, after they've had an accident and years later, they're still in pain? Why? I have no idea. If I did, I'd be very rich. Kind of trying to figure out what causes chronic pain. There's a lot of people doing research on that because so many people suffer from chronic pain. Now, the chronic pain is actually described as more of like aching or dull. Some people may say throbbing. Now, that information is carried along type C fibers, which are slow. Now, C fibers are smaller in diameter and they're not myelinated. Now, where is it felt? Well, this is more diffuse. It's not as well localized, but it's often can be deep instead of more superficial, like with acute pain. But it can be associated with the skin. Now, here's the reason why they call it chronic pain: is you have removed a stimulus, but the pain continued. So it continues after the stimulus. Is removed. Now, chronic pain doesn't necessarily mean forever, and there's like a cutoff. Like if the pain continues for a certain amount of time after, like healing should have taken place, or the stimulus is removed, that's considered chronic pain. But eventually, in some instances, that can go away. It lasts longer than it really should. Now, acute pain rather than chronic pain, we can talk about the concept of neuromodulation, which we're going to do very shortly. But I do want to mention visceral pain versus somatic pain. Now, somatic pain is coming from your skin, your muscles. Now, visceral pain are coming from internal body organs. Now, not all your organs are painful if they're damaged or messed with because of innervation, if you don't have innervation to it. The localization of visceral pain is poorly localized because there's not a lot of sensory afferents coming from it. But one thing to keep in mind is you don't have to injure something to be painful. You cut the bowel, that's an injury, but it's not necessarily painful. You stretch a bladder, not injuring it, but it's painful. So don't always correlate injury with pain. So you can have pain without injury. Now, with visceral pain is often exhibits what we call referred pain. Ignore that picture. So what's referred pain? Well, referred pain is where you have pain in a location other than where it originates from. The reason is that the visceral pain receptors, or these sensory afferents coming from the visceral organs, there's not a lot of them. It's not as common. And they converge upon the same second order neuron here in the dorsal gray horn. And it's converge on the same one, say, coming from the skin. So what's going to happen is this is going to be sending information up to the brain, and the brain's going to interpret is it coming from the area of the skin rather than the actual visceral organ. And so we get what we call referred pain. So just to give you some examples, is pain associated with the heart. It doesn't necessarily have to be right on the chest, but it can be up in the shoulder area and down your left arm. You see, like in the movie, someone grabs their left arm. It could also be associated right between your shoulder blades. And in some instances, like especially with women, they have pain associated in their jaw when they're having a heart attack. You'll notice with the liver and gallbladder, you're not thinking like, why is this liver and gallbladder when you got pain in your right shoulder? So let's be like, why is that hurting? But you also see it right over here in the upper right quadrant. Ureters, you see a low back, but also down into the groin area. Kidneys, you also see a lot of people with low back pain. I remember when my dad had one of his heart attacks, he was sitting at the kitchen table and he's like, why is my shoulder? He says his shoulder was bothering him, his arm was bothering him. But he was also starting to exhibit, he was sweating, some other issues. And my mom knew right away, we need to get you to the hospital because you're having a heart attack. So the pain, lots of times, I had pain associated with my gallbladder and my pancreas, and I was even thinking it was gallbladder or pancreas because I'm like, why is my back hurting? Because I actually had pain starting on my left side and it went all the way around my back, and it was really painful here. I was like, why is my back hurting so bad? But it was actually, I was having a pancreatitis attack, and it was extremely painful. Now, how can we modulate the pain? Is actually, I'm going to jump ahead to this picture. And so it's going to go through some of the stuff, and you don't have to try to draw everything out, but you have the painful stimulus, you transduce that pain up to the spinal cord, then you have that second order neuron that's going to transmit that information up that lateral spinal thalamic tract, and then in that thalamus you have that third order neuron, and that's taken up to that primary somatosensory cortex. And notice it's going over here because it came from the hand, and again it's on the other side because it decussated. You perceive the pain, so okay, I'm aware it's painful, but then we actually can modulate pain. So neurons from the brainstem can relieve neuromodulators. I'm not going to call them neurotransmitters. I'm going to call them neuromodulators that can actually block that pain impulse. So one of the important things that we have that are neuromodulators for pain is our endorphins. So endorphins are our natural opiates. So you see opioid receptors, and this is how some opiates work. Is what can happen is these neuromodulators can do one of two different things. It can block the release of neurotransmitters from here, which would block the transmission of pain. And in some instances, it actually can block these receptors over here for those neurotransmitters. And one of the things that endorphins do is they block the release of something called substance P, which is a facilitator, which really makes sure that, the information in regards to pain is going to be sent up that spinal cord very quickly. But once you're aware that it's happened, let's modulate it. Let's decrease it so we can decrease that pain transmission. So the endorphins actually help to modulate that pain. Now, with that in mind, I do want to mention something called insensitivity versus indifference to pain. Now, the insensitivity to pain is you have sensations, but you don't have perception. Indifference to pain is different. Indifference to pain is you have perception, but your response is different. But I want to talk about insensitivity to pain. So insensitivity to pain could be caused by an increased endorphin levels. In some instances, they believe where we have insensitivity to pain is there's mutations in voltage-gated sodium channels. And there's multiple different types of sodium channels, so they're not all the same, but one's involved in this pain transmission that people that are born with a congenital insensitivity to pain, with a mutation in this receptor or in this channel, you're not going to be able to transmit the pain impulses. They can feel other stuff, they just can't feel pain. There's a condition called leprosy, which is caused by a mycobacterium, which leads to granulomas of nerves, which result in these people's lack of ability to actually feel pain. But congenital insensitivity to pain is very rare, but a lot of people want to study these children and eventually adults because if they understand this, they can maybe work on be able to modulate pain better. But it's not a good thing to have insensitivity to pain because they don't realize body parts are injured. They can end up getting infections and losing body parts as a result of it. And that actually does happen with leprosy, which is not an true insensitivity to pain, but they have the lack of the ability to feel pain because of the granulomas of these nerves that result, and they do lose body parts because they don't feel something is, and these are actually, I hate to say this, the leper colonies, it came up, was not really great sanitation, or they have a lot of rats and mice, and at night the mice might be chewing on a body part that people can't feel it, and so they lose body parts. I hate to say that, but that sometimes happens with people that have leprosy. So I just want to end here, and we'll talk about some other pathways in other recordings.